My name is Emma Clippinger, and I'm a senior at Brown.
And I'm Emily Morell. I'm a senior at Yale.
And we are co-founders, co-directors of the nonprofit Gardens for Health International, which we will also be referring to as Gardens for Health, or GHI. Emily and I met in the summer of 2006. We were both interns with the Clinton Foundation HIV/AIDS Initiative working in Rwanda. We were both moved to action by the Clinton Foundation's very noble mission of achieving universal access to life-sustaining drugs for HIV/AIDS individuals. However, that summer, we both learned that malnutrition severely undermined the effectiveness of these drugs. Before we begin, I would like to thank the University of Texas, Dell, the RGK Center, and all of the judges for giving us the opportunity to present here today. It's very exciting. Emily and I live and breathe this organization. We are not the only ones, though. We are supported by an outstanding team in Rwanda, and it is really because of them that we can stand up here today and share our program with so much confidence. So I'm going to turn it over to Emily to explain the theory and some of the thoughts behind our mission and work.
So what you see here is truly a frightening paradox. Thanks in large part to efforts of the Clinton Foundation and other organizations to reduce the price of these life-sustaining drugs known as antiretroviral therapy, or ART, these drugs are widely available throughout Rwanda at low cost and elsewhere in sub-Saharan Africa. However, as Emma mentioned, malnutrition severely compromises the effectiveness of this treatment. To give you an example, a study in 2007 done in Rwanda showed that 73% of HIV patients beginning their treatment cited poor access to food as the biggest obstacle to the treatment adherence. So Gardens for Health is working to address this dilemma by targeting malnutrition and HIV/AIDS simultaneously. HIV/AIDS and malnutrition form what is known as a vicious cycle. That means that each exacerbates the effect of the other. A person with HIV or AIDS requires additional caloric intake, suffers from nutrient malabsorption, and is highly susceptible to weight loss. Malnutrition further enhances these negative effects and contributes to suppression of the immune system. Malnutrition also contributes to poor treatment because it disrupts normal drug metabolism and further alters nutrient reabsorption. So we are working to break this vicious cycle. Nutrition interventions can help turn this vicious cycle into what we call a virtuous cycle. So through improvements in nutrition, you get improvements in adherence to those antiretroviral drugs. And with that, you improve your immune function. You're less susceptible to opportunistic infections such as tuberculosis, which is a major cause of mortality among AIDS patients. And thereby, you slow disease progression and prolong life. You also improve quality of life. So that's what we're working towards. However, most nutrition interventions currently in practice in international development today do not promote that virtuous cycle. Instead, they rely on short-term supplies of food aid. So what's wrong with food aid? First of all, it's micronutrient poor. It doesn't contain the vitamins and minerals that are required for proper nutritional status. It's also short-term, so it fosters dependency. If you're an HIV patient who goes to one of the few health centers that receives this UN support, where you're going to get this weekly ration, you're going to get a packet of corn and soy flour, which comes all the way from Saudi Arabia. You're going to get 8 ounces of corn oil, which comes from the US, and you're going to get 8 ounces of sugar, comes all the way from Malaysia. And this is very short term. You will only receive this ration for 6 months. So if you're a mother who is receiving this ration, recently diagnosed, you're probably not going to take the time to plot your crops that season. And by the time that ration ends, you're going to have very little food left. And so it creates dependency for both the patient and also for the country itself, because it reduces local, it de-incentivizes local productivity. So the Gardens for Health model is working to create a better alternative. We include 4 integrated components into our model. The first is land rights advocacy. The second is provision of improved agricultural inputs. The third is facilitation of nutrition education and training in sustainable agriculture techniques. And lastly, we invest in small-scale agribusiness ventures. So Emma's now going to give you a little bit more in detail about this model.
Thank you. In 2007, we formed an official partnership with the Rwandan Network for People Living with HIV/AIDS. This network works directly under the National AIDS Control Commission, and what it does is it oversees the activities of nearly 1,000 community groups of HIV-positive individuals. So what we do is that we provide legal support to these community groups so that they can become legally registered small business cooperatives. A small business cooperative has a bank account, has bylaws, has internal mechanisms for self-governance. But most importantly, a small business cooperative can go to their local government and advocate for free access to wetlands. Wetlands allow for continuous growing. So this is especially important in Rwanda, where land is arguably the country's scarcest and most valuable resource. Rwanda is sub-Saharan Africa's most densely populated country, but 90% of the population relies on subsistence agriculture. So working through the cooperative model, we strengthen the capacity of existing organizations. Some of these community groups have been in existence and have been working together for nearly 15 years. Furthermore, we allow a particularly vulnerable population to pool their labor and resources. The next component of our package, agricultural inputs, the dominant crops you see in Rwanda are sorghum, maize, and bananas. And they're easy to grow, they're cheap, but they are starches, they have little to no micronutrient value. So in an effort to increase micronutrient intake, we provide agricultural inputs, fortified seeds, fruit tree seedlings, which are expensive, labor-saving tools, and locally produced organic fertilizer. What we do then is we quantify the total monetary value of this investment, and we look for payback over a period of about 2 years. We also provide, with the package, community or home gardens. And home gardens we give to the more vulnerable members. Our agronomists oversee these. They're sacks or sometimes even tires filled with vegetables, and they ensure immediate food security. We do not look for repayment for those. So as a result, cooperative members have access to a wide variety of nutritious foods that they would not otherwise grow because the seeds are prohibitively expensive or because the necessary labor is seen as just too intensive. Most importantly, though, they have access to a source of income. Surplus crops are sold at local markets, and the surplus is used to pay back our initial investment and also to support cooperative activities down the line. So we work closely with a nutritionist at the Rwanda Network for people living with HIV/AIDS, and the nutritionist designed a series of intensive nutrition trainings, and cooperatives elect some of their members to attend these trainings, and then they're salaried by their cooperatives to become peer nutrition counselors who visit the more vulnerable members to monitor their health. And also, all members actually are invited to attend weekly nutrition trainings that include cooking demonstrations and meal planning. And also on the agricultural side, our agronomists are trained in techniques that really maximize the productivity of small plots of land. Our agronomists are top of the line. They've gone through many years of education in Rwanda. So on their side, they train members, cooperatives will elect members to be salaried to reach out to individual members once again. So as a result, we can ensure the long-term success of the cooperatives in monitoring both their nutritional status and in improving their agricultural practices.